Heel strike, stance phase. Okay.
Hip and thigh, inspection of pelvic and hip alignment, skin and subcutaneous tissues, and surrounding musculature.
Okay, like I said, you're going to be looking at the landmarks, ACEs, right? Making sure they're lined up. There's no contractures or pelvic obliquity. What else was it? Skin, yeah, ecchymosis, edema. Yeah, look for any, like we talked about earlier, the atrophy of the anterior thigh, atrophy of the buttock. Okay.
Palpation, major landmarks, ASIS, greater trochanter, iliac crest, initial tuberosity.
Start with the iliac crest. Trace down. Yeah, it's a lot easier to feel these ASIS.
It's all about atrophy.
The PSIS. Let me see. He has the dimples of Venus. Turn around.
Of course he does.
Damn. Dimples of Venus.
It's not much different. It's
PSIS, ASIS.
Ladies like back dimples.
No.
My wife does.
Mid-trochanter, right?
all the women said no.
Mid-trochanter.
Range of motion, active and passive, flexion, extension, abduction, adduction, internal and external rotation.
All right, I'm just gonna have you lie down. Can you lie down for me, please? Okay, just ask you to hold your chest for me. Release chest, flexion, good. Relax.
I'm gonna get closer.
Okay, have you bring your leg out to your side for abduction. I need some new shorts, man. You bring them back, bring across, adduction. I'll have you roll over on your belly for me, please. Okay, I want you to bring your left leg up, please. Okay, now your right leg. Good. You could assess the strength in the same way. Relax. Turn over. Internal, external rotation. Oh, sorry, I forgot. Put your foot on the deck. That's it. Good. Okay. Bring your knee inside. Internal. Okay. Now your knee outside. External rotation. Okay. Strength. Strength in the same manner, except for when you do it for internal and external rotation, like this. So external rotation, push against my hand.
Did you really have to do it that way?
No, you don't. What's the other way you'd like to do it?
Well, can we do it this way?
Like how?
Like have him push,
Have him
like
push
up against my
down,
hand
or-
and then push down
If
against my hand?
he has his leg crossed or
Yeah,
whatever?
just like that.
Sure. Yeah. As long as the actual movement is internal and external rotation.
So up will be internal when they're pushing up against, right?
Right.
No, no.
And then out
Yeah, I
would
think
be
it's-
external.
Otherwise I get confused.
Okay. Okay. Cool. So
You think
you
about
guys
it.
got it for flexion
Already got
extension. You guys got that? Flexion extension, AB, adduction, push out against my hand, push in against my hand like we showed before. Okay, that's strength.
Special after strength and special test is the Nilberg test, Thomas, Saber, Waffle,
Alright, so I'm just gonna ask you to do this. So just raise up your right leg for me, please. Alright? Okay. Looking at the level of the PSIS, I'm looking for the leg that's unsupported to droop down. That'd be a positive test. That's negative. Okay, good. Lie down for me. Lumbar. Scour. Just bring your knee up.
Scour, you said?
Yeah. Relax. Alright, there's a couple ways you can do it. This is the way that I think it shows in the book here. You just put an axial load down, right? A little bit. Relax a little bit. Alright. So a little bit of adduction, right? And then axial load. Scour. Looking for labral pathology. Bring it neutral. And then a little bit of abduction. Good. Okay, so any clicking, grating, pain. other way that I saw it that I kind of liked, because if you're short, you have to reach up to kind of push down. Bring the leg up, and then just use both hands on top, because now you can use your body weight to kind of push yourself down on the person and then scour. You're still scouring, just because you don't see this happening, or this isn't moving, you're still scouring. Push down, scour.
Looks so painful.
Scouring.
Okay? Put your body into it. Okay?
You were measuring.
Okay, good. Can you bring your knee up to your chest, please? Good, you can use your hands. You can use your hands to grab it.
What you're saying
A little tight. You're a little tight. Brother Thomas. Okay, the log roll. Looking for femoral neck pathology. Okay, do that on both sides. What else am I missing? Okay, piriformis, can you face me, line your side, face me? Okay, good. Flex your hip up to 90. Okay, good. Face him here, here. So it's adduction, internal rotation, right? So just push in, push down. Okay, and you're looking for pain from the down the buttock to shoot down the leg. Type piriformis, sciatic impingement. And then what else? Piriformis, favor. Okay, cross your leg over. Okay, this is the one I was talking about. Not to just push down forcefully. So support the hip. This is for SI pathology, sacroiliac pathology. Push down. Push down. Is that painful? Little. See, I barely even push down. Face kind of tight though. Yeah. All right, so that's the Faber. Okay, good.
What does that check for each one?
Sacroiliac. Any issues with the sacroiliac joint? Low back pain.
Knee and lower leg. Inspection. Genu valvum, genu valens, and genu rectum.
Recurvatum. So genu verum and valvum. So verum would be what? Out, right? Like bow-legged. And then valvum would be knock knee, right? So I'm looking at that from here. That's pretty good. Good align. And then for recurvatum is going to be if you see any like extra extension on the knee joint, right? So that you're going to have to assess from the side. Okay, that looks good. Okay, so tracking, have a seat here. Okay, just going to have you extend the knee. Right here I'm looking for a J sign. Or any exaggerated movement of the patella. Very good. Okay, breathe from me.
Skin and subcutaneous tissues, surrounding musculature, vastus medialis, oblique definition.
Okay, so that's one of the first things to go. VMO definition, right? Vastus medialis oblique. When you have an injury, this will atrophy first, right? Yeah. Good. All right, so look for atrophy of VMO. Skin and subcutaneous tissues, same things we're always looking for, erythema, edema, those things. Okay?
Palpation, joint line, major landmarks, the patellar tendon, tibial tuberosity, tibular head, pes, aneurysm bursa, and iliotibial band.
Okay, so the joint line is best palpated when the knee is in flexion, right? Because then when you flex it, then the joint opens up, right? So you can palpate the joint line. So have the patient flex the knee, find the tibial tuberosity, right? And then palpate the joint line, like so. Okay. Any pain and tenderness in the joint line is going to be like maybe like a meniscal injury or something like that. What else? Other landmarks, right?
Patellar tendon.
Okay. Patellar tendon. Just go down to the edge. Okay, so patellar tendon, patella. The tendon kind of runs down right here, and the tibial tuberosity attaches at the tibial tuberosity. Okay, any tenderness there at all? No, because that's fine bursa. So if you find the tibial plateau, so it's just medial on the underside of the tibial plateau. All right, any tenderness there is indicative of bursitis. It's usually like an overuse thing. If somebody's like running a lot, they weren't used to running a lot, has anserine bursitis.
Fibular head and IT band.
Fibular head is best felt in a figure 4 position, so you can have the patient cross their legs like so. You can actually see the fibular head here. Here, it's right here. So palpate the fibular head. Okay, good. Relax here. IT band. So it's like a, excuse me. Relax. So it's a band-like structure. It's really thick. Runs down the side of the leg, down to the tibia. Any tenderness at all? Pain? Okay. Inspection, palpation.
Range of motion, active.
What about the LCL? LCL? Is that in there? No. Okay.
Range of motion, flexion and extension.
Okay. One of the mistakes that the patients make, or the students make, is they'll test the flexion and extension from here. So they'll say, all right, can you go ahead and straighten your leg out, please? Okay, good. That's good for extension, but what about for flexion? They can't because the bed's right here, right? So usually I just have them stand up. Right. Okay, good. Go ahead and bend your knee back. Good. Or you can also do that with assess the flexion with the patient lying down. If you have like a goniometer or something to get the angle. Okay, flexion, extension, strength, same. So go ahead and push out against my hand. Good. Pull in. Okay, good. So,
Special test, patella apprehension sign.
okay, lie down. You actually have like any knee problems? You're not very flexible.
I do. You should do
His
mine.
knees are all fucked up.
Yeah. You should do mine
Yours?
exam. Be all positive.
Okay. For patella apprehension, all you're doing is you're finding the patella, you're moving it medially and then laterally, and what you're looking for is for the patient to feel like a sensation like the patella is going to sublux or dislocate. And what you'll see, if they feel that, in an attempt for them to try to stop it, they'll flex their quadriceps really hard to keep the patella in place, right? So that's the positive patella apprehension sign. Okay. So varus valgus, right? Varus valgus. Okay, so varus valgus you assess at 30 degrees first, right? Varus valgus at 30 degrees, and then after that you assess it fully extended. Okay, so 30 degrees. Bring the knee to about 30. You can support it with your hand, and then push. What am I assessing right now? LCL, right?
So varus.
Varus. Straight. Right? Oh, same thing, straight. So fully extend it. Straight. And then the other way, right? Sorry, I just did that. Pushing in, so now I'm doing valgus at 30, and then it's straight. Another way you can do it, scoot over just a little bit, and you just hang the leg off the bed and do it the same way. Varus valgus, instead of like supporting the weight. So if you don't want to hold the patient's leg in your hand, just kind of bring the leg off to the side, it's an abduction, varus valgus. So, so like this, right here, I'm assessing the medial collateral ligament, and if I push the other way, I'm assessing the lateral collateral ligament. Okay?
McMurray's test.
McMurray's test is assessment for like a meniscal injury, meniscal tear. So what you want to do is you want to make sure your fingers